Welcome back, everyone. I'm delighted to welcome Dr. Joanne Bargman, who is going to give one of the first of her two talks on peritoneal dialysis. Dr. Bargman is one of the world's leading authorities on peritoneal dialysis. She's based in Toronto at Toronto General. She's the former president of the International Society of Peritoneal Dialysis. And she's a wonderful teacher, and she's been recognized with many awards and accolades. But I'll just call out specifically the Bob Nairns Award from the American Society of Nephrology, which goes to a leading nephrology educator. So, Dr. Bargman, we're really delighted to have you join us again this year. Thank you.
Thanks, Kevin, and thank you very much for inviting me. Hi, everybody. I'm going to talk about peritoneal dialysis in two parts. The first is a general introduction on how it works and basic principles, and then the next part will be to talk about some complications related to the therapy. Here's my bio. And here's my relevant disclosures, and here's the objectives to my talk. So we'll talk about transperitoneal transport, peritoneal dialysis solutions, how do they work? I'll touch on adequacy of PD, although I could probably spend a whole hour just talking about that. And then I'll also touch on management of volume status in the PD patient. So here's a question for you. This is a woman with type 2 diabetes who starts on PD, and a couple of months later, she undergoes a peritoneal equilibration test, or the so-called PET, and it shows that her D over P creatinine at 4 hours is 0.9, which classifies her as a high or a rapid transporter. And the D over P of 0.9 means that after a 4-hour dwell, the dialysate creatinine concentration is about 90% of what it is in the plasma. So, which of the following statements is true? And you really don't have to answer it right now, but just think about it. The D over P creatinine is an important predictor of adequacy. The PET at 2 months was performed too soon after the insertion of the PD catheter. There may be problems with ultrafiltration, especially during the long dwell of the dialysis fluid, and icodextrin is not particularly useful for the high or rapid transporter. So just think, if you had this question on your exam, what you thought would be the best answer. In the meantime, we'll talk about how peritoneal dialysis actually works. And if you just look at the peritoneal cavity on the right, and the capillaries that perfuse the peritoneal cavity comprise the vascular compartment, and that is on the left. And it is separated by the peritoneal membrane. Now let's zoom in a little bit on this separation, or this interface between the dialysate compartment on the right and the blood compartment on the left. And the way I understand it goes back to my grade 12 chemistry, where we used to have a two-compartment setup separated by a bidirectional semi-permeable membrane. And that's certainly how I learned all about diffusion and convection and osmosis and stuff like that. And that comes in really handy for understanding how peritoneal dialysis works. So here is a more magnified view of the interface between the dialysate compartment on the right and the blood on the left. And now we can see that there's more layers. So going from left to right, on the blood side, there are endothelial cells that line the capillaries of those blood vessels. Then there's interstitial tissue. Then there is the peritoneal membrane. Then lining the peritoneal cavity are mesothelial cells. And then we have the dialysate compartment itself. And current studies suggest that the regulation of transperitoneal transport actually occurs at the level of the capillary endothelial cell. Nowhere else, not the mesothelial cells, but actually the endothelial cells of the capillaries that are perfusing the peritoneal cavity. So, how does solute get from the blood to the peritoneal fluid? Well, just like hemodialysis, by diffusion, and also by convection during ultrafiltration, just like in hemodialysis. Diffusion from the blood to the dialysate is going to be fastest in the first hour, because that's when the concentration gradient is the most, but then it lessens over time. And we know just by measuring it that after about a 4-hour dwell, urea is almost completely equilibrated, more than 90% equilibrated, whereas creatinine, which is a bigger and more slower moving solute, is about 60% equilibrated. So after a 4-hour dwell, you're not going to remove a whole lot more of urea, but The long dwells are more important for removal of the more slower moving solutes, such as the middle molecular weight and the larger molecular weight retention or uremic solutes. So put graphically, this is the D over P or dialysate to plasma ratios. 1.0 would mean 100% or complete equilibration, and so on. So you can see for urea, which is easily diffusible, that it rapidly equilibrates between the dialysate compartment and the plasma, whereas creatinine moves more slowly, and middle molecules are essentially time dependent. And the longer you leave the fluid in, the more middle molecules you will remove. Interestingly, remember that the peritoneal membrane is a bidirectional membrane. So not only does stuff travel from the blood to the peritoneal fluid, but it can go in the opposite direction. And that can come in handy sometimes. For example, antibiotics. If you have a patient who needs, let's say, 6 weeks of antibiotics for osteomyelitis or for an infected vascular graft or something like that, you can use the intraperitoneal route to obtain therapeutic blood concentrations. So before you go and whip a PICC line into your PD patient, which more often than not leads to bacteremia, see whether you can give the antibiotics intraperitoneally and measure blood levels. This is especially very easy to do if you're giving vancomycin. And remember, a blood level is a blood level, whether it comes from absorption from the peritoneal fluid or from an intravenous line. For some reason, ID doctors don't seem to understand that and feel that you have to give the vancomycin IV and not IP. And that's not true because, like I said, a blood level is a blood level no matter where it comes from. So there's lots of things that you can give in the peritoneal cavity that will get absorbed into the bloodstream. Fluid removal in PD is done by osmotic pressure compared to hydraulic pressure in hemo, but the results are the same as mentioned before, ultrafiltration and convective removal of solutes, which as you know is disproportionately more important for the larger molecular weight uremic solutes. So this is the composition of the dialysate fluid, the 1.5%, the 2.5%, and the 4.25%. And you can see that with the higher dextrose concentrations, you get higher osmolality. So how does that work, the osmosis? Well, again, back to grade 12 chemistry. You've got your two compartment separated by a semi-permeable membrane. You put in a hyperosmolar PD fluid, and you generate an osmotic gradient from left to right, from the blood compartment to the dialysate compartment. And therefore, if you know osmosis, you know that water is going to move from an area of lower osmolality into an area of higher osmolality. And that is how ultrafiltration occurs. But it doesn't move just as distilled water, it will carry stuff with it. So that's where we get also convective removal of other solutes along with the ultrafiltration. Unfortunately, and this is one of the Achilles heels of peritoneal dialysis, is that the dextrose, which generates the osmotic gradient, has its own concentration gradient between the PD fluid and the blood. So, the glucose concentration in a 4.25% bag is 3,860 milligrams per deciliter. And blood glucose is somewhere around 100. Even in a poorly controlled diabetic, let's say it's 400, there's still a big gradient for glucose between the peritoneal cavity and the blood. So the glucose will diffuse out of the peritoneal cavity over the time of the dwell. And because of that, you get an ultrafiltration curve. In other words, you see the ultrafiltration volume on the y-axis and the time on the x-axis. And over time, you start off with rapid ultrafiltration because the osmotic gradient is the greatest right at the beginning. But then you lose the osmotic gradient and eventually you reach osmotic equilibrium and net ultrafiltration stops and you start to get absorption. And in fact, if you leave the the dwell in long enough, you will end up with net reabsorption. And that is probably because of the loss of the osmotic gradient plus ongoing lymphatic absorption of dialysate out of the peritoneal cavity. So if you have a patient who's on night cycler PD, let's just say for 8 hours, and then they have one dwell all day, which is 16 hours, you understand that that's a very long dwell time, and you could end up with net reabsorption. So, for example, if you put in a 2-liter last fill bag and kept it in for 16 hours, when the patient goes to drain it out, they might have, let's say, 1,500 from the original 2,000 that they put in, or they've absorbed about 500 mils of the dialysate fluid. It isn't necessarily the end of the world, and it doesn't mean that you've got to automatically change the dialysis prescription. If they're careful with their fluid or if they've got a lot of urine volume, then it may not be a big deal. But it's just important to note that it certainly is a risk with the long dwell that the patient may end up absorbing the dialysate fluid. Again, from measuring in lots of people, we know that a 1.5% usually results in ultrafiltration of about 300 mils or so. And the time to that time of maximum ultrafiltration is just about 2 hours. Now, most dwells are left longer than 2 hours, and that is why if you drain out a 1.5% after a 4 or a 6-hour dwell, you usually end up with no net ultrafiltration or even a little bit of absorption. The 4.25, on the other hand, has a maximum ultrafiltration of about a liter, and the time to that maximum ultrafiltration is about 4 hours. So that you can see is pretty impressive ultrafiltration. So here's a question for you. If a 4.25% solution typically leads to 1,000 mils of ultrafiltration over 4 hours, that is an average of about 250 mils per hour, which is pretty good hourly ultrafiltration. So why, when PD patients enter the ICU and they need fluid removal, why do the ICU doctors end up switching them to hemodialysis? And the answer is I have no idea, except that they really don't trust PD and they feel way more comfortable removing fluid with extracorporeal therapy rather than peritoneal dialysis. And you as nephrologists have to push back about this idea of automatically switching a patient to hemodialysis if they enter the ICU. Remember, it's just entering a whole other source for infection. It's a big deal, and very often these patients can be jollied along with peritoneal dialysis. So this is a computer-generated ultrafiltration curve just showing the difference for each strength of dialysis. So you have the 4.25 in green, and you can see there's way more ultrafiltration and it lasts longer. And then as you go to the 2.5 and the 1.5, you can see you get less maximum ultrafiltration and it goes away sooner. But with either the 2.5 or the 1.5, you can see that if you leave it in long enough, you end up with net reabsorption. So the amount of ultrafiltration in peritoneal dialysis depends on three things: the strength or the tonicity of the dialysis fluid, the duration of the dwell, as I explained, and then the third thing we haven't talked about is the intrinsic permeability of the patient's peritoneal membrane to glucose. And if you have someone who has what we call, or what I call, a leakier permeable membrane, or they're a more rapid transporter, then glucose will dissipate faster out of the peritoneal fluid, and the osmotic gradient will dissipate faster. So again, here's the peritoneal equilibration test, which is used to characterize the peritoneal membrane. It says nothing about adequacy of dialysis. It's just saying, how does this patient's peritoneal membrane work? And this is actually kind of intellectually interesting, because in hemodialysis, all the membranes are made in a factory, and whichever one you pull off the shelf is the same as the one beside it. But this is a biologic dialyzing membrane, so it will be different possibly between patient A and patient B, and it may change over time within a given patient. So that is why you can characterize the membrane with this peritoneal equilibration test. So what you do is you put in a hypertonic solution into the peritoneal cavity, and you just let it sit there for 4 hours. And then during that 4 hours, the creatinine will diffuse along its concentration gradient from the blood into the peritoneal fluid, and glucose, as I described before, will also diffuse along its own concentration gradient from the dialysate into the blood compartment. And how quickly does all that occur? And that is quantified by the D over P creatinine at 4 hours. And the leakier the peritoneal membrane, it's not like it's really leaky, which I'll explain in a second, but the more rapid transport the patient is, the higher the D over P creatinine, because more of the creatinine will have diffused from the blood or the plasma compartment into the dialysate compartment and get closer to equilibration. And therefore, the D over P creatinine will come closer to 1.0 or 100%. So this is a leaky peritoneal membrane where everything's moving faster, and you can see that the glucose will move out pretty quickly and the creatinine will move from the blood to the PD fluid pretty quickly. And that's what characterizes a rapid transporter. Now, it isn't like they've got big holes in their peritoneal membrane, which is what makes it leaky. It's actually that in the blood compartment, if there's more open capillary beds, it makes for a greater sink for both presentation of solutes and also of absorption of solutes. So when I say that they're a more rapid transporter, they really just have more open capillary networks or capillary beds. So that's the leaky peritoneal transporter, whereas the slow or the tight peritoneal membrane, the slow transporter, has fewer open capillary beds, and therefore the creatinine doesn't move all that quickly from the blood compartment into the dialysate compartment, and vice versa for glucose. So because of that, you can do this PET. Now, urea, because it's so easily diffusible, you can see is not really that much of a discriminator among different patients, whereas creatinine, because it's bigger and slower moving, does splay more among different patients. And therefore, you can divide these data into quartiles, with the rapid transporters in red having faster transport of everything, and the low in purple, or the slow, having less transport over the 4-hour dwell. And that is the basis of the PET. So the rapid transporters have a so-called leakier peritoneal membrane, so glucose will diffuse out of the peritoneal cavity faster, and unfortunately that means that the osmotic gradient will dissipate sooner, and that has very important implications for ultrafiltration. So why are some people rapid transporters and why are some people slow transporters? Interestingly, rapid transporters are associated with higher markers of inflammation. And in some studies, it's more common in diabetics who may actually have a higher level of generalized inflammation. And interestingly, the low serum albumin is seen even before the PD catheter is put in. In other words, once the PD catheter is put in and after a couple of months, the serum albumin is low. But if you look back, these patients, even before they had the PD catheter put in, already had a lower level of serum albumin, suggesting that maybe a rapid transporter just reflects generalized inflammation. So this is the slow transporters. They will have the opposite. The glucose will hang around longer in the peritoneal fluid, and therefore the osmotic gradient will be maintained longer. So when you look at the drain volume, which is really the ultrafiltration, you can see that if you put in 2,000 and the drain volume is 3,000, that you've actually ultrafiltered 1,000. And you can see that the slow transporters, the purple ones, have got the best ultrafiltration, and the rapid transporters in red have the least ultrafiltration. And really, we used to call them high and low transporters, thinking that the ones where solutes went faster actually removed more solute, and therefore they were high transporters. But when you realize that the high transporters have better diffusive flux on your left there, that's in the D, but less convective flux because they have less ultrafiltration, and vice versa for the slow transporters. In the end, they're not really all that much different from each other. So that's why people have gone from saying high and low transporters more to rapid and slow transporters to pinpoint events that are actually happening across the peritoneal interface. So back to the patient that I talked about at the beginning, who had a PET that showed that they were a rapid transporter. The right answer, I hope that this is the one you chose, is that there may be problems with ultrafiltration, especially during the long dwell of dialysate, and that is because of the faster dissipation of the glucose osmotic gradient. So in terms of the other potential answers, during a long dwell, well, that will explain the rapid dissipation of the osmotic gradient, and this all happens faster in the rapid transporter. Okay, a little more deep dive into transperitoneal flux. This is a woman with who's on night cycle or PD, and the nephrologist wants to impress the administrator and CMS with a high KT over V urea, and so prescribes 5 cycles over 9 hours with a hypertonic dialysate. And the patient complains of marked thirst in the morning and has to drink several glasses of water. So what's going on here? Is it the sleep apnea syndrome seen in dialysis patient leads to mouth breathing and thirst? The patient may be hypernatremic in the morning because of sodium sieving. The glucose absorption increases serum osmolality and drives thirst, or the morning thirst is the result of resetting of the osmostat. So again, if you encountered this exam question, what do you think would be the best answer? So again, if we look a little more closely, again, we have the blood compartment on the left, the capillaries, and the dialysate compartment on the right. As I said before, it appears to be the endothelial cells in red that are lining the capillaries that control the flux between the two compartments. And there are 3 kinds of pores at this interface. There's the space between the endothelial cells, and most of these are small spaces, so they're called small pores, and they allow water to go through and electrolytes and small solutes. There's very few, but there are large spaces between the capillary endothelial cells called large pores, and they allow everything to go through, including macromolecules and larger molecular weight uremic solutes. The third pore is the aquaporin, and it goes right through the endothelial cell, and it only allows water to go through. It is activated by hyperosmolality. It is not ADH sensitive the way the aquaporins are in the cortical collecting tubule of the nephron. These are non-ADH sensitive, but they are activated by hyperosmolality. And when that happens, the aquaporins turn on and water can move into the peritoneal cavity. So that is where sodium sieving comes in. So if you put in a hyperosmotic PD fluid, you activate the aquaporins. And the thing that happens the fastest is that water goes through the aquaporins. And then what happens more slowly after that is that water and small solutes go through the interendothelial cell small pores. But if you're doing rapid exchanges, you may be catching the water only movement through the aquaporins before the movement through the small pores catches up. So you end up removing much more water than sodium. And what happens when you remove more water than sodium? The patient will end up with more sodium than water, or in other words, hypernatremia. So sodium sieving means that more water than sodium is going into the peritoneal cavity in short dwells. In long dwells, it all sort of evens out, but in short dwells, which is what happened when the nephrologist cranked up the number of exchanges overnight, the sodium is held back or sieved at the level of the aquaporin, and therefore there's more water removal than sodium removal. So remember, this is with the use of rapid exchanges with hypertonic solution. And I just want to tell you that because everyone in the United States is so obsessed with KT over V urea, that PD patients in the United States get a lot of exchanges with, as you can see there, bordering on 5 exchanges overnight on average. So the best answer here is that the patient is thirsty in the morning because they're probably hypernatremic and sodium sieving from the rapid hypertonic exchanges. Remember, aquaporins allow only aqua to cross the endothelial membrane, and the rapid exchanges will lead to more water removal compared to sodium removal, and the result will be hypernatremia, which is a powerful drive to thirst. And if you tell the patient not to drink, they won't listen to you because it's like telling a hypoxic person not to breathe. Like they just have to drink, and they will drink themselves back into their tolerated osmolality. And I just want to point out more recent research shows that there are different aquaporin genotypes from one patient to the other, and it does appear to affect the amount of ultrafiltration. So again, it adds to the interest that there is in dealing with a biological dialyzing membrane in peritoneal dialysis patients as compared to hemodialysis patients. Now, you should know about icodextrin. It doesn't work by regular osmosis, it works by colloid osmosis. And the way I think about this is supposed to be just a blood vessel as a way to explain Starling forces. And you will remember Starling forces say that delta P pushes fluid from the vascular compartment into the interstitial compartment, and it is balanced by the oncotic pressure mainly generated by albumin that's in the vessel compartment and not in the interstitial compartment, that sucks the fluid back by oncotic pressure into the blood vessel, and they usually stay in balance. So that's the way I think about icodextrin. Those big dextrans in the peritoneal cavity are kind of stuck there, and they're kind of like what I think of albumin in the vascular compartment, even though the osmolality is no different between the interstitial compartment and the plasma compartment. Same thing with icodextrin. It is not hyperosmolar. It just has those dextrans in it, which account for the increase in oncotic pressure. Now, this has an interesting clinical result. So back to dextrose for a minute. This is crystalloid osmosis with dextrose. You get activation of the aquaporins. So we know that about 50% of the water of the ultrafiltration goes through the aquaporins and about 50% through the small pores. Whereas with icodextrin, because it is isoosmolar, it doesn't activate the aquaporins. So the only ultrafiltration that is occurring is through the interendothelial cell pores, and that is relatively isonatric water and sodium removal across here. And the reason why this is important is that if you look at a liter of ultrafiltration, if it's a liter of ultrafiltration with dextrose, half of that is pure water through the aquaporins. So you'll end up with a liter of ultrafiltration that is kind of like half normal saline. It's half water and half isonatric, so that the sodium concentration will be about half normal. Whereas with icodextrin, because all the water removal is occurring isonatrically, the sodium concentration is about 130. So you're getting bigger bang for your ultrafiltration buck by using icodextrin because you're getting more sodium removal per amount of ultrafiltration than you do with dextrose generated ultrafiltration. So that's the clinical relevance of all of that. Okay, let's move on to Marvin. Marvin has GN and starts on APD. You can see his prescription. He's on 2 liters times 3 exchanges overnight with a last fill of 2 liters. He still has a lot of residual kidney function. His GFR is 9 mils per minute. He pees nearly a liter. And by the way, for average people, a residual GFR of 9 mils per minute is somewhere around a renal KT over V of 1.8. So for those of you who feel compelled to always be following the KT over V urea, if you include the residual kidney function, already his total KT over V before you've even done any peritoneal dialysis is already 1.8, which means that certainly when Marvin is starting on PD, you can give him any prescription just to let him get used to it, and it will fill the bill. So that's what's going on with him. And what do you think about Marvin? I'm looking for an incorrect statement here. He's protected from ECF volume overload in part by the residual urine volume. B, he probably has borderline adequacy and should have his dialysis prescription increased or be converted to hemodialysis. He should be, in order to preserve his residual kidney function, he should be advised to avoid nephrotoxic insults, and 8 hours of APD is appropriate for many patients. So what's the wrong answer here? And I would submit that the wrong answer is that he has borderline adequacy and should have his dialysis prescription increased. He's on a very reasonable PD regimen. In fact, I would probably give him less than this. He has a lot of residual kidney function, and there should be no question about adequacy at this point. And like I said before, he would probably even do fine with a lower dose of PD while he had this degree of residual kidney function. So just a word about adequacy of peritoneal dialysis. The strength of PD lies in its continuousness, the preservation of residual kidney function compared to hemodialysis, and the kidneys are good at getting rid of middle molecules, and so is the peritoneal membrane. The kidneys are not, the peritoneal membrane is not particularly brilliant at getting rid of urea. So I cannot understand why we would measure adequacy of peritoneal dialysis using a urea-based metric. And like I said, I could go on about this for about an hour. So I'm happy to say that the latest iteration of PD adequacy from the International Society of Peritoneal Dialysis is much more on the ball, I think. And what they talk about is shared decision making, take into consideration life goals, minimize symptoms, and I would highlight minimize the burden of therapy, preserve residual kidney function, and don't forget about nutrition and, of course, volume status. And I really think that is the best approach to adequacy of PD, not KT over V urea. So talking about fluid balance, how do we deal with that in PD? Well, there's intake and there's output, and the output is urine volume and urine output, and also ultrafiltration by peritoneal dialysis. So volume overload in the PD patient may be excessive salt and water consumption or diminished output, and that could be loss of residual kidney function over time, the use of the wrong dialysis fluid, such as, for example, a 1.5% for the long day dwell. You just know you're going to get fluid absorption. And like I said, it may not be a big deal, or it may be a big deal. The failure of the peritoneal membrane to respond to the osmotic stimulus or the oncotic stimulus, and that's true ultrafiltration failure, and mechanical problems like leak of the dialysis fluid into other parts of the body, which I'll talk about in the next lecture. So loss of residual kidney function is probably the commonest cause of progressive fluid overload, and it's variable. I have patients right now who have been on PD for 10 years and still have between 500 and 1,000 mils per day of residual kidney function. Plus, you can use diuretics to augment urine salt and water output, such as loop diuretics or even metolazone, as long as the patient has got some residual kidney function. So, of course, try to protect the kidney function and treat your dialysis patient who's lucky enough to have residual kidney function just like you would your CKD 3 or 4 patient. And if you wouldn't dream of giving your CKD 4 patient, let's say, a non-steroidal anti-inflammatory drug, then don't give it to your dialysis patient who has residual kidney function. We also continue immunosuppression in patients who have failed, quote unquote, failed transplant kidneys, because even if they can chalk along and with 5 mils per minute of transplant kidney function, that is a lot and can really ease the burden of the dose of peritoneal dialysis. And the burden of therapy is really important. So the use of the wrong type of PD fluid I mentioned before, using a non-hypertonic or a non-icodextrin type of fluid, and then you'll end up with net reabsorption. Again, let me just emphasize that if the patient is euvolemic and they're peeing a lot, if you have a long day dwell and they absorb some of it, it's not necessarily the end of the world. You don't necessarily have to change the prescription, but just be aware that if they lose residual urine volume, that then they may run into problems with volume overload. So what do we do with the long dwell? Well, use a more hypertonic dialysate or break it up to refresh the osmotic gradient. Or, like I said, it may not need any intervention if the patient is euvolemic. No need automatically to change the prescription. And for output dependent, there's failure of the peritoneal membrane to allow ultrafiltration or true membrane failure or mechanical problems. So for true membrane failure, if you put in a 4.25% bag for 4 hours, you should get more than 400 mils of ultrafiltration. And if you don't, then you're dealing with true membrane failure, which actually isn't all that common. These are very rapid transporters who have very rapid dissipation of the osmotic gradient and end up with poor ultrafiltration. But in fact, this can be helped by icodextrin. And here's an ultrafiltration curve for icodextrin in the blue. And you can see even in rapid transporters that it's very good at removing fluid. So icodextrin can be really your ace in the hole when it comes to ultrafiltration in someone who's a very rapid transporter with membrane failure. So you also want to push the residual urine output with diuretics and APD, perhaps with, if you can get away with it, day dry, or if not, maybe a shorter day dwell, or the use of icodextrin. But if you have a very rapid transporter, once they lose urine volume, they are really at increased risk of volume overload, and you should be talking to the patient about transfer to hemodialysis rather before it becomes a big emergency. And then finally, the output dependent on, like I said, such as leak of dialysate fluid into the soft tissues, I'll talk about in the next lecture. So about a year later, Marvin comes to clinic and he's now volume overloaded and hypertensive, and his creatinine's gone up. So what's happened in this year? The increased serum creatinine from when he started to now reflects a failure of solute transport. He most likely has peritonitis. The new onset hypertension is likely the result of acquired renal cystic disease, or both the rising creatinine and the peripheral edema can be explained by decreased residual kidney function. And the correct answer here is D. The explanation being that it would explain a decrease in creatinine clearance would explain the increase in serum creatinine, and also the decrease in urine volume would explain the volume overload. Because and peritoneal membranes tend to become more, not less permeable to solutes over time. You can't say that there's been like some sort of block in transperitoneal creatinine transport. That really doesn't happen. So if you see serum creatinine going up over time, 9 times out of 10, it's because the renal creatinine clearance is decreasing. So how can we help Puffy Marvin? Salt restriction, high dose diuretics, and try to increase ultrafiltration in the ways that I described. So in summary, The rapid transporter has increased peritoneal bed capillary vascularity and transports small solute more quickly. Unfortunately, it also loses the glucose osmotic gradient more quickly, and they may have problems with ultrafiltration. The slow transporter is the opposite. Short hypertonic dwells lead to removal of more water than sodium, leading to hypernatremia. So avoid short hypertonic dwells. Don't forget about residual kidney function. As you know, it's one of the most important predictors of outcome in our patients than anything measured by small solute kinetics. Please don't obsess about KT over V urea. I know you have to report it, so get to the minimum target, but and use the renal KT over V in your calculations, even though kidneys do so much more than get rid of urea, and obsess about other things in your patients, including volume status, protecting the residual kidney failure, please, burden of therapy, and quality of life. And I'll stop there, and I have some reference for you that you can have a look at your leisure.